So one tilting is you are tilting palatally. You are starting buccally, but you are tilting palatally. But there is one more tilting. Start from the palatal, tilt towards the buccal. You will get actually long bone sometimes.
We are not going to no.
This is the buttress area. This canine buttress. Okay, but actually I am not doing this tilting. Just palatally it is more easier because we keep the finger and track along it. If we try this now, it may come out also. We don't know. So to prevent that, you need to open flap till here. If you are planning for this tilting, you need to open flap. So all on four they open till here, till the nasal floor and all. Okay, so some kind of compromise, not very much palatally, not very much buccally. This you can do. So when I tilt one implant from 5, if I want to keep the plan very simple, I will place one implant in the canine region.
Anyway, we have canine, the bone height is little high, right?
Yes.
So we can utilize canine always in any cases.
So basically, you need to place 3 implants, that's it. 1 implant, 1 2 or 1 3, 1 implant, 1 5 slight mesial tilt. If you do the tilt room too much, you cannot place 2 implants here. You can place only 1 implant here. That's it. That is the concept. But here, with slight mesial tilting, I can catch good bone. So we can do 2 implants here and 2 implants here.
One side 5.
One side 5 implants. Palatal socket of 6, 7, 8, whatever it is. If 6 is not working out, we will use 7 and 8. If 6 is working out, 6 and 7 is enough. Why to go till 8? So we will plan for 2-1. 2-1, there is no need to plan actually. It will look very similar to the left side. So this is a very ideal scenario. Even though there is lot of bone loss, the presence of palatal bone. And one more thing is, how to tell whether the patient has got palatal bone without seeing. There is one simple technique is there. If the patient is having a shallow palate, they will have a lot of good bone. Patient with a deep palate, they will put their thumb here and they suck. That is how the deep.
Okay.
So their palate will be like this. But that here the palate is very shallow. Okay. So if children thumb suck, no, you can tell this. Future full mouth, it is very difficult for you. You will not solve that. You will not solve that. And one more tip is there. Okay. Patients with a long face, they will have deep palate. So by seeing the patient himself, you can tell you will have less palatal bone and you will create a headache for us. Oval face, they will have a deep palate. Orthodontists know this better. This square face, the morning square face we saw, no? They will have lot of palatal bone. We saw palatal bone, lot of good palatal bone. Okay, this is the thing. So patient's face, outline gives us lot of detail. Square face or oval face, these things. The patient's square face, they give lot of bone, but they give lot of force also. Force also. But patients with oval face, less bone, but they cannot generate much force. So many ortho points come in FMR. So actually we will see the 2-6 area first. 2-6, this quadrant will be quite easy because he is chewing on only one side. So definitely this side bone loss will be less. So this is the mesiobuccal root. Excellent bone because the crestal bone has not resolved. If it is resolved, then it will be difficult for us. Definitely we can use a very long implant. Go along the palatal wall. We can place a good implant, nice implant. Even up to 16-18 mm implant we can place. This is more than enough. We don't have to go behind it all. We don't have to see 7 and 8. Anyhow we will see. We will see the palatal socket. See, this is the palatal socket. It is almost similar to extracting a good teeth with good bone. Right? Yes. Palatal socket, beyond the apex, you have got lot of bone. So you have two options. One is using a 5.5, but that is not a good plan because you have got lot of bone here. Why to waste this? Why to get stability from here? If you use a wide compressive, it will get stability from here, and it will get stability from here also because you are using a wide implant,
Only
4.2.
for single extracted
Yes.
case, you go with
Yes.
5.5
Yes.
palatal.
Yes. Here you
You
have
less till that.
yes. Here compression implant you can use 3.75 or 4.2, but this is better because here it snugly fits the socket wall.
Wide.
If you use 7.5, there will be gap here and there. It won't get snugly. So if you use 4.2, it will get stability from here. It will get stability from here also. If you use a 5.5 here, it will get stability only from here. This bone is best.
But okay.
So by chance, while going in that way, in case we do fracture this,
No, it looks like it is very thin, but it won't fracture.
it won't.
It won't fracture because it's a very thick bone actually. So that is why what she's telling is right. Sometimes when I feel no, it is very thin, I will keep one finger on the palatal side. So it will expand also. It won't fracture, but it will expand, no crack and all. But stability will get once you connect to the other implants, it will integrate. So using palatal socket for implant placement, there are lot of articles are there. So each month you have to allot one area to one. So read, go deeper, because all this knowledge is only a beginning point. See, 7 and 8 bone loss is there, right? They are not ideal. Maybe 7 mesial aspect. Okay, this is 7 mesial aspect, but 6 is good. Okay, we will stop till 6. Okay, just
15 minutes break and something.
just time actually. Now we have to plan the 4 and 5, right? We'll plan the axial 5. Axial planning in 5 without any tilting. You can place, provided you do the palatal angulation. If you go through the apex, no, you will enter the sinus. But if you tilt here, you may end up in good bone. So that is what we are going to do. We are not going to tilt mesially, because the moment you tilt mesially, placing other implants becomes a trouble. Inter-implant distance, implant hitting each other. So there is a good bone available with little palatal tilting, not mesial tilting. About 18 mm or 16. So 5, no tilting. So in 4 and 5, 2 implants, one area, 1 implant, that is enough. 3 implant is enough in the first circle.
4 and 5,
1 that is enough. Since you are using longer implant, you cannot place implant in between. They will hit each other. When you are using very longer implant, you can reduce the number of implant. You don't have to summarize the plan. Here 6, 7, 8, intraoperatively we will use it, but 2 implants. 5 slight mesial tilt, 1 straight. In between implant you can place anywhere in 1, 2, or even 1, 4 slight mesial tilt, or even from 1, 3.
here.
Yes, 3 plus 2. Here 3 plus 1. 1 is in the mesial root, no?
6 or 7.
Yeah, palatal socket of
Palatal
6.
socket of
Palatal socket of 6. So totally 9 implants. If you use a screw retain, it will finish in 6 implants. That's it.
We cannot place more than that in screw retain.
Not necessary. Not necessary. See, the screw retained is at the max 6 is better, because the more the number of implant, you may have fitting issues, you may come, and the milling time will increase more number of implants. If the implant is only 4, it will mill within 3 to 4 hours. If it is 6 implants, it may take 8 hours. If it is 8 mm, it may take 10 hours. So the lab cost also will increase according to that. Actually, in tilted implant book, they have given the point reducing the number of implant is necessary to get a good fit of the processes, screw retained. In single piece, if there is any misfit, it is not a problem. It is getting compensated in cement thickness. But here you need precision, because you are going to tighten with screw. There should not be any misfit. The more the number of implant, the more the chance for misfit. The machine will love when there is less implant. It will mill easily. Because each and every implant there is one, if it fits no, it takes lot of time to mill. Those things we can see today in lab.